I'll tell you as soon as we see it. There we go. I can see the entire screen. You just want to share the presentation though.
Okay, and I don't know why it's not doing that. Give me one sec.
What time is it there on your side, Simene?
Allow to share window. It's 3 o'clock.
Okay.
I'm not sure why it won't share. Give me one
So I'm
sec.
going to share from my side.
Is it sharing now?
Yes, it is.
Okay. All right. So that's fine. I'm gonna quickly press down. Can you see it now?
I think it's almost there. Or is it
So
just
is it presenting now?
no, it's a bit blank. Okay, to save time, I'm going to share from my side, Simene.
Okay.
All right, please confirm that it's visible, Jean.
That's visible. Thank you very much.
Okay. Simene, you let me know when you want me to move the slides, please.
Okay, that's fine. Good morning, everyone. Thank you for the opportunity to present my research to the education faculty. My name is Simene Joffe, and my doctoral research is titled An Exploration of the Parent-Therapist Relationship when Supporting a Child Exposed to Trauma. I'll begin with a brief crisis, not a lengthy discussion of the background, as that was presented in the first doctoral presentation. I'll then move on to a reflection of the literature and the identified knowledge gap. Then I'll focus on the study methodology, discuss the research findings and their presentation, then talk about the contribution and limitations, and end with a brief conclusion. In the first doctoral presentation, I explained that the extent to which happenings at the interface with parents of child clients has a strong bearing on treatment outcome. In all parent-therapist interactions, there's the possibility of difficulties or barriers occurring. Broadly speaking, these issues might be referred to as resistance issues, non-compliance issues, or treatment interference issues. These challenges and tensions have the capacity to interrupt the working relationship between the parent and the therapist, interfering with child treatment outcome as it leads to cancelled appointments, non-attendance, and early termination of therapy. Can we be on the next slide, please? Very little attention has been paid to the complexities in the parent-therapist relationship regarding the impact of child adversity and trauma presentation when working with trauma exposure, which could improve child treatment outcome. The research study explored the gap by examining the complexities in the relationship between the therapist and the parent to determine if there were any specific articles for parent or therapist when working within a trauma-informed approach to better understand the tension and difficulties in this situation to optimize child trauma treatment efficiency and outcome. The next slide. The central research question in the study was how can the parent-therapist relationship be supported when working with a child who has experienced trauma? The research sub-questions were the following. What are the therapist's perceptions of their experiences of working with parents whose child has experienced trauma exposure? What are the parents' perceptions of working with therapists when their child has experienced trauma in psychotherapy? And what are the similarities and differences between therapists' perceptions and parents' perceptions when working with children in psychotherapy? The research objectives of the study were to examine the therapist's perceptions of working with parents, to interrogate the parents' perceptions of working with therapists, and then to compare the similarities and differences between the two groups, and then to finally explore how the parent and therapist relationship can be supported when working with a child who has experienced trauma. The next slide, please. I now move on to the literature review. There are extensive studies demonstrating that trauma is a global health crisis, as it is prolific and has an immense impact on child development. If left untreated, it has large psychological impacts. While there's compelling material to demonstrate that evidence-based trauma-informed psychotherapy treatments are effective in treating childhood trauma continues to be widespread, and child psychotherapy services remain underused, have low retention rates, and high attrition rates. The literature also demonstrates that child psychotherapy is contingent on parent support, as parents seek treatment, finance treatment, and ensure treatment attendance. Therefore, parent investment and support influences child attendance rates and treatment outcomes. Therapists' work with parents is important, considering that parents play such a vital role in the child psychotherapy process. In fact, the therapist's relationship with parents protects and secures child therapy outcomes. Various studies highlight the importance of working with parents, aligns barriers in parent work, the impact of parent trauma exposure on parenting capabilities, and the importance of therapists applying support mechanisms like a trauma-informed care approach. Yet negligible attention has been paid to the parent-therapist relationship and the relationship factors at play regarding the impact of childhood adversity and trauma presentation in parents when treating a child for trauma. The literature shows more research is needed to determine any specific obstacles for therapist or parent when working within a trauma-informed approach. To address the gap, the present study explored parent perspectives and therapist views of parent-therapist relationship to identify any obstacles that prevent the formation of a robust working relationship. The findings from the study generated information on complexities within the working alliance to assist therapists in working efficiently and collaboratively with parents to improve child treatment attendance rates and outcomes. The next slide, please. The study's methodology adopted a qualitative approach and was informed by an interpretivist paradigm. As outlined in the specifics in the first doctoral presentation, I'll focus here on the data collection tools, sample, and ethics. 15 therapists and 15 parent participants in Perth, Western Australia, were purposely selected to provide the data. The research sites were United Relationships, Western Australia, and psychologists in private practice. United Relations was selected as it offered a comprehensive specialized family violence services for children and parents who had experienced trauma. I was able to access these participants as I had established a personal relationship with United Relations in 2007 when I was employed by them in the specialized family and domestic violence services as a psychologist, and this continued for over a 4-year period. The data collection methods in the study were the questionnaires, Adverse Childhood Experiences Screening Questionnaire, and a self-reflective journal. Questionnaires were used as I needed a tool where there was no face-to-face contact with the researcher to maintain participant confidentiality. The second data collection device was the Adverse Childhood Experiences Questionnaire and was used to identify exposure to childhood trauma experiences. This tool did not require direct contact with the parent participants and was self-administered. The third data collection tool was a reflective journal where I recorded and reflected on personal assumptions, decisions, and role in the research. Regarding ethics, all participants gave their voluntary informed consent. Confidentiality and the participants' privacy and personal data was maintained throughout the research process. Risk to the therapist group was low, as they received mandatory clinical supervision. There was a medium risk for the parent participants, as the research was personal, and some of the parents may have come from vulnerable groups. I implemented steps to reduce the risks by being aware of the possible vulnerability of parents, taking care not to cause them any harm or re-traumatization, and provided them with the option to access psychotherapy services for debriefing and containment. Presentation of the results. Next slide, please. I presented the results by structuring the qualitative findings according to the 3 research questions. The experiences and perceptions of the 15 therapists obtained from therapist questionnaires and the self-reflective journal were structured around the first research question and were presented in a table summarized into themes and sub-themes. An example of this is in green on the PowerPoint. The experiences and perceptions of the 15 parents derived from the parent questionnaire, the ACE screening questionnaire, as well as the reflective journal was formed around the second research question and is also presented as themes and sub-themes in a table. The data obtained from all 30 parent and therapist participants was collated into themes and sub-themes and was organized around the third research question, similarly presented in a table format. Hierarchical tree diagrams were used throughout to represent the sub-themes. The qualitative results were supported by raw data in the form of verbatim extracts, and some of these were also presented, as well as the extracts from my self-reflective journal. Next slide, please. I will illustrate this by reading two participant extracts. The first is by parent Sage regarding what she would have liked to share with her child's therapist, but was unable to. I come from a generation different to yours, where there was a lack of mental health. Feelings and words were suppressed. I live in a different world to you. For me, life was about survival. It is unfortunate that my experiences have had a negative impact on my family, but we are here now. I may not be a health profession, I may have poor health, but I am intelligent and I care. The second extract is by therapist Gavin, who highlights the importance of working within a trauma-informed model when working with parent trauma survivors. Understanding that therapeutic resistance is usually generated by trauma phenomena rather than willing resistance or poor compliance to treatment. Understand that the most difficult parents are the most traumatized parents. Understand that even poor parents are only doing their best. In dealings with parents, especially when they're angry, critical, and demanding, know that at the base, they are actually tired and scared that things won't work out well for their child. Next slide, please. I will now discuss the findings in relation to the research questions and how they provide information to fill the literature gap. The findings pertinent to research question 1 illustrate that a strong parent-therapist alliance is a valuable mechanism to facilitate child emotional recovery, since a therapeutic alliance itself fortifies treatment investment, improves parent functioning, and upskills parents to promote trauma healing. Although therapists are motivated to work with parents, they encounter barriers, including reduced parent investment, parents not fully committing to the child's treatment, parents' personal trauma, and therapists' own difficult and complex feelings. Yet therapists have the skills to manage and mitigate the alliance barriers to effectuate a successful working alliance. The findings from research question 2 reveal that there are times when parents experience dissatisfaction within the child psychotherapy process. This is when they're not included in the child's treatment, pre-treatment expectations are unmet, they perceive interactions with therapists as negative, or believe that therapists don't respond appropriately to their trauma needs. These generate feelings of disrespect, anger, and disappointment, causing parents to disengage from the working alliance and terminate treatment. The findings that emerge from question 3 indicate that parents believe that role confusion disrupts the working partnership, whereas therapists suggest that reduced parent emotional capacity and parents behaving in resistant, non-compliant, and treatment-interfering ways create alliance difficulties. Therapists also highlight that they encounter parent resistance and non-compliance when treating a child for traumatic distress. However, most therapists in this study were trauma-informed and contextualized parent-resistant behavior as normal protective behavior and maladaptive coping mechanisms after trauma. The findings substantiated in the trauma theory, which advises that when therapists are trauma-informed, apply trauma-informed treatment models, and have a formulation for working with parental resistance, a stronger alliance is developed. Therapists and parents also corroborate that parent attachment difficulties and alliance ruptures also impact the alliance, and agreed that a positive working partnership can be enhanced through strong parent-therapist skills, promotion of collaboration and mutuality, and therapists providing parenting resources. The results that emerged from the study were underpinned by a trauma theoretical framework, which confirmed the need to be a decrease in unresolved trauma. The findings offer therapists new understanding of the complexities in the working alliance, which enables them to better manage and support the parent-therapist relationship when working with children with trauma. The next slide, please. I'll now move on to the contributions of the study. Contributions to research and the body of knowledge. This is a first study, to the best of my understanding, on comparing and contrasting parent and therapist views on the complexities that occur in the interface between parents and therapists in the psychotherapeutic setting. The contribution to the existing body of knowledge is by providing insights in relation to understanding the frustrations, tensions, and obstacles that happen in the working alliance in the broader context surrounding the circumstance of psychological treatment of children exposed to trauma. The study will contribute to practice by providing therapists with the following information on how to better manage parent-therapist cooperation. First, trauma-informed practice combined with a trauma-informed care approach is necessary when working with parents, as most parents have experienced trauma themselves. Second, therapists need to perceive parent attitudes and behaviors in the context of trauma and see difficult or oppositional parent attitudes and behaviors as normal responses or ways of coping. Unresolved parent trauma needs to be managed and contained. Third, parent treatment expectations need to be explored and role clarity needs to be provided to parents. Fourth, therapists need to provide both emotional and practical parenting resources to improve parenting self-efficacy and parent reactions to child trauma. Finally, therapists need to be self-aware in regard to their own feelings when working with parents. The findings recommend the need for further study to be undertaken across a larger sample size to support the possible recommendation that child psychologists working within the universal healthcare system and or in a school setting will be required to have specialized training to work with parents whose child is engaged in psychotherapy for trauma-related issues. This wider study could influence policy review or change to assist in addressing the broad social issue of childhood trauma. Next slide, please. One of the limitations of the study was generalizability, as the findings cannot be generalized to all parent-therapist alliances in all psychotherapeutic circumstances. But the aim of research was not generalizability, but a deep understanding of the context within the research. Another limitation was the methodological limitation of dual therapist researcher role, that the literature evidences as long as the qualitative researcher understands how she's influenced the study and takes steps to minimize the bias, it's acceptable. The study answered the central research question by providing new information and insights into the challenges within the parent-therapist relationship to help therapists understand how to better manage and support the working alliance when treating a child for trauma. This will improve the longevity of trauma-informed psychological treatment and the social issue of unaddressed childhood trauma, which has lifelong impacts on parent functioning and capacity. The findings that emerged from the study were underpinned by a trauma theoretical framework. A trauma theoretical framework was used because trauma is central to the treatment and management of complex therapy cases. Whilst therapists help children with complex trauma, treating young people involves interfaces with parents who may have complex trauma. My reflections. The greatest challenge during the research process was to be a researcher and not a psychologist. I managed to achieve this by meticulously keeping a reflective journal and using a modified Gestalt therapy technique. Next slide, please. In working with the therapist data, I kept slipping into the child therapist headspace. I needed to find a way to separate my researcher self from my therapist self to keep the role objectivity throughout the study. I decided to borrow the two-chair psychotherapy technique from Gestalt therapy. In Gestalt therapy, the client is given two chairs, each representing a different part of themselves. Thus, the client moves between the two chairs to act out to the other part of themselves. I used a modified version to separate the two different parts of myself, researcher part and therapist part. Whenever I worked with a therapist data set, I checked to make sure that I was sitting in the researcher's chair. However, if I find myself in the child therapist chair, then I metaphorically move myself back to the correct chair. Can we go back a slide, please? In conclusion, The study aimed to identify and understand perceived obstacles and barriers that interfered with the development of a strong working alliance between therapists and parents to optimize child trauma treatment efficiency and outcome. Essentially, the study found that the therapeutic relationship is one of the most profound experiences in which therapists can engage parents with trauma histories to increase treatment outcomes, consequently safeguarding traumatized children from themselves becoming traumatized parents or adults. Thank you all for taking the time to attend today. Yeah, now I can hear you.
We are on time, so thank you for going through your seminar with us. I'm going to ask the supervisors if they can questions or queries, and then we'll open it up to the floor. Okay, so Maxine, you're hearing us. Good.
Dr. Jean?
So I'm
able to
not
hear
sure
me?
if Veronica has sound in. She was sound earlier, but the other supervisor, co-supervisor is Dr. Mabasu, and maybe Dr. Mabasu would like to invite the doctoral committee. Seems like people are having trouble with sound or technology today. Prof. V, we've got him today.
Can you hear me now, colleagues? Am I audible?
Yeah, now it's better.
Yes, we can hear you, Prof.
Okay, good. Thank you so much. Dr. Jean, we would welcome responses or questions from the floor. Prof. Max was one of the doctoral seminar committee members, and he's off sick. And the other person has subsequently resigned from university, so we have a challenge of having anybody here as part of the doctoral seminar. Thank you. I'm wondering if the problem is on Jean's side.
Seems like sound is the problem today. Dr. Mabasu, yeah, Prof. V, we can. You are?
Jean, I think maybe the challenge is from your side because you're breaking up, or is it just me? I'm just going to ask, are there any questions by raise of hands, please? And then we can take questions.
So if there are any queries or comments from the floor, people seem to be intermittent today. So if anyone on the floor has anything to say, please, is open for questions. So Simene. In the absence of other people coming up.
Sorry, it's just extremely difficult to hear. You keep cutting out and just coming through in bits and pieces.
Simene, I don't know if you're able to hear me.
I can't hear you. I could hear Professor Dorico when she was coming through, but I can't hear you.
Jean, I've muted you on my side. I think possibly the challenge may be on your side. It's very, very faint and we can hardly, it's breaking up excessively. Thank you. We'd appreciate if you put your comments in the chat. Colleagues, is there anybody else that has feedback for Simene? Comments on how she could improve before she submits in the next few weeks? Oh, it's either everybody's frozen, Simene, or you did an excellent job and everybody's excited for you. Congratulations on your presentation and everything of the best.
Thank you, and thanks for doing the slides.
Yes, you're welcome to stay on to see the chat if people are putting any comments on, or you'd like to listen to other presentations. All the best.
Thank you.
I'm just checking who is next to present.